Thank you so much to those of you who have been joining us on YouTube for Tuesday trainings, and for those of you who are just newly joining us, I'm just over the moon. I've actually been weekly on Tuesday trainings for several years, and never intended at all to, build a YouTube channel or anything like that. It's still not my intention. But what I love about the channel building is that means that we're all joining forces and in like a hive mind of community training. And that is what really lights me up. So we are officially well over 1,000 subscribers on the channel, which just blows my mind, actually. I know there's channels with millions of followers, but again, that was never my intention to build a channel. But what it does mean is that there's over 1,000 of us every week that are tuning into Tuesday trainings or joining live for Tuesday trainings. And so I wanted to celebrate that. I wanted to celebrate that we're a growing, broader community than just my weekly community that I meet every day in my, paid programs, so to speak, because I still consider you guys family. So I love that you're all here, and I love teaching. So that makes it super fun for me to have you guys here. I put together a topic that I think kind of matches a lot of the questions that I get asked a lot, which is I have a client with X, Gina, what do I do about it? What do I do? Why? And we spend a lot of time on Tuesdays during Tuesday training talking about this curtain number one idea, this base anatomy, this functional anatomy. Like, you get to know your anatomy, you get to know how it works. And then when your client shows up with XYZ, you have a better foundation from which to draw a conclusion. And still, sometimes it's, Gina, get on with it. I have a client with XYZ and I need to answer that. So that's what we're going to highlight today in our specialty celebration class here. I haven't met you officially, so wanted to let you know that I am both a manual and movement practitioner. My work as a body worker started decades ago. And unlike the popular statistic in our industry, I've been at it full time that whole time. And I love it. And I want you guys to be at it full time and love it. And I started as a manual practitioner. In my personal life, I was a movement practitioner, and then recognized that there were movement patterns that, oh wait, these two lanes could be shared. The manual and the movement could be shared. I still don't believe that we have to be both, but I do want us to have the anatomy for both. I think there's gaps for both lanes. And so that's what I'm here to do, is to fill those gaps. So and my whole business is on getting rid of pain and then preventing it from coming back, or preventing it from being here in the first place. So we don't have to market that we're in the business of pain. The whole point about pain is not that we focus on it or don't focus on it. The point about pain is that when we know how the body's designed and how it's designed to move, there won't be any pain. It doesn't matter if you're a yoga student or a prenatal client or getting a weekly massage. If we move the way we're designed, there won't be any pain in all of the things that we like to experience physically in this lifetime. So that's really what I'm talking to. Not that we are pain specialists, although you could be, but how do we move efficiently in all the things that we want to do? And how do we stay out of discomfort? Okay. So that said, I picked 5 top chief complaints that I hear the most, and I want to walk through them today. So sciatica is pretty common. I've heard lots of iterations on where that comes from, how to solve it, and I have a better answer for you. Rotator cuff, which seems to really be daunting for a lot of us. We usually do get a rotator cuff client or patient from the avenue of physical therapy, so that can also create some clarity and also some confusion. So I'm going to talk to you guys about that. Plantar fasciitis, which seems to be certain pockets of people. It comes, it goes. It's this thing. It's not a thing. It's a thing. I'm going to talk to you about it, but the thing is not the thing. We'll talk about that. Fallen arches, which a lot of folks say, well, I'm unable to do whatever you're asking me to do because I have these fallen arches, but the fallen arches are a whole thing in itself, and that's what gets to be addressed. So we're going to move through those. And what I want to share with you is the common culprit, what it actually is, the anatomy that goes with it, and how to simplify resolving it without dancing around symptoms. Okay, so I want to do that with these 4 to start with, and we'll see if we have more capacity for more, I'll always add in more. And I also want to just thank you guys for being here and trusting me in this time. I was hearing from lots of folks, not just here in our community, but in other groups that I'm in and in email. And I mentioned it today in Tuesday training, that we're all pretty fatigued with like, where do we get this answer from? And are we going to get sold something else? And is this just a ploy for me to come and hear a sales pitch about something? I, interestingly enough, just also saw an ad yesterday that captured my mind, had nothing to do with anatomy. And I clicked on the ad, and the next thing you know, I'm in this funnel and I couldn't even click off the ad. It just kept sending me to the next page. And I was watching it, sort of like watching the bigger picture, like standing out from the side and watching it while also listening to the content that I was genuinely interested in. And I recognized that what I was noticing was one of the reasons why we don't find what we're looking for, because we're so tired of being pitched to. Does that resonate with you guys? Are you guys tired of being sold? One more workshop, one more extra thing. Yeah, I totally get it. So thanks for being here. It says a lot about your commitment and your faith, and also that I've earned some of your trust, and I love that. And I am not here to sell to you. This is not a standard webinar where I'm going to talk for 20 minutes about something that I have to sell to you. I'm not. And I do have a year-long program. And if you don't know about that, I want you to know that that is what I teach, all of the solutions to what we're going to cover today. So I'm not going to sell you on that program, but I want you to know there's more for you. And that's the line that we all get to walk. Like, if we have something and I don't tell you, then how do you know I have something for you? But if I tell you, then you might feel sold to. It's really tricky right now in business, like to walk that line. So thank you for being here. And I'm happy to answer questions for you. And that's about that program, the mastery program. And that's not what I'm here for today. Okay. I mean, I'm not here to sell that to you today, but if you have questions about it, that's what I'm happy to answer the questions. So some highlights for what we do in the program is going to be in the solutions to these common chief complaints. And that said, in a 90-minute session, I probably won't be able to give you every single thing that you want to know about every single part of the anatomy. Hello, guys, it's 90 minutes, right? So I just want to manage expectations. I'm going to give you a ton of content, and then ask me where you have questions where I haven't filled your cup enough. Okay. Okay, we work with that. Does that sound like a workable session? Okay, beautiful. Amazing. Okay. So let's start with sciatica. Okay, so sciatica is pretty common. Pregnant women, yoga students, massage clients, personal training clients, all age brackets, it seems anyway. And so there's a lot of commonality and also a lot of confusion about it. I'm not going to hot seat you guys, but I would love for you to answer in your mind. And if you want to be hot seated, that's a great way to learn, by the way. You could blurt out an answer. It's just us, so that's fine. What do you think is the source of sciatica? And what I mean by source is what we're going to look at for all of these common conditions. So my background as an overall practitioner is an orthopedic background, not relaxation or restorative yoga or anything like that. I love all of those things, but I was into like solve the problem. In order to solve the problem, you have to know where the problem starts. And what we tend to do as both manual and movement providers is we recognize the symptoms because our clients recognize the symptoms, and there's a lot of fear that gets generated by the symptoms, and it's distracting and it's shiny object. And that is 90% of the time. This is real numbers, not just my drama. 90% of the time, the symptoms are not where the source is. So even when we find muscles that feel tight, that's a symptom. Because muscles don't just spontaneously get tight. They get tight because something caused that. The cause is the source. The cause is the genesis. So I want us to turn our brains into where do we really think it's coming from, not the identity of tight muscles, for example. So again, I'm going to ask the question again. I gave you a little bit of buffer time in there. Do you know, you can just do show of hands. Do you know, or do you really think you know the source of sciatic pain? Anybody feel like they really know? Oh, Gary, maybe? What's kind of maybe?
That's my Queen's wave.
So good.
The Queen's wave.
I appreciate the legality. So good. Okay.
Just off the top of my head, I'm saying nerve compression.
Okay.
Is the source.
Okay.
Nerve compression. How it's compressed, we'll get into that if I'm correct, but that's what I said.
Okay, love this. I'm gonna actually just reach behind here because I want to go give you guys some images. I want to show you. I love the nerve compression idea, Gary. And so is it, am I assuming that you mean the sciatic nerve compression or some other nerve compression?
Sciatic nerve, yeah,
Sciatic nerve.
compression on the sciatic nerve. Yeah,
Okay, amazing.
yeah.
So love this. Yes. And here's what I'm going to also offer for us. With all diagnoses, it doesn't matter what side of the aisle we're on, manual or movement. We know that we're not able to diagnose. And the president of my massage therapy school actually said, because I was really struck on this, I'm like, if I can't diagnose, how can I figure out what's going on that I can fix it? Like this feels like a mind game to me. And his answer was really helpful. He said, you can diagnose insofar as what you treat. And I was like, so you mean I can diagnose, but then not tell anybody? He's like, no, no, no. Insofar as what you can treat. And I was like, I don't know what that means. And he made me like go away and think about it, which was part of this strategic thinking that I'm now giving back to you, right? Insofar as what I can treat, what the freak does that mean? Here's what I came up with and why I was asking you the question too, Gary. We get to know in any diagnoses, we get to know what concluded the diagnoses to be stamped by someone who can diagnose. What were all the factors that they collected that said these many factors equals this diagnosis? So we need to know what those are. We can't make those claims and we can't make the diagnosis, but we need to know what makes up sciatic pain. What is that diagnosis? And you called it, Gary. It's about the nerve. It's about the sciatic nerve. This diagnosis is a little easy because it actually has the thing that they're calibrating in the diagnosis name. We don't get that lucky all the time. So this is a helpful one to like learn this, like where's the source coming from? So in sciatica is a diagnosis that has to do with the sciatic nerve. Helpful, great. And so here's what we want to know about the sciatic nerve. We want to know where it is. If you're going to navigate a diagnosis on a particular body part, you got to know where that body part is. That's the foundation that I was offering you guys. Like, you got to know the anatomy. Like, if you know the anatomy, it helps you with so many things because it just creates this body of clarity. So we need to know the anatomy on the nerve, and we need to know what's happening to the nerve in this particular diagnosis. And you called it, Gary. It's some kind of irritation. It could be compression. It can be some other type of interruption, if you will. And interruption of nerves usually follows 4 different types, quality of symptoms. Again, we're on symptoms, but it's numbness, tingling, shooting, and burning pain. Those are, and some of us know those and we're like, yep, got it, Gina. And some of us are just being reminded of that. And that's totally cool too. So just because we have numbness, tingling, shooting, and burning pain in a particular nerve doesn't mean that that nerve is pinched, because now we're into diagnosis land again. Doesn't mean that it isn't, but it doesn't mean that it is. It can just be irritated. And again, using our anatomy to help us with that, nerves don't like to be infringed upon. They don't like to share their space. They would make terrible New Yorkers, I joke all the time. I would walk to the subway in New York City and I'd be bumped 17 times. It's amazing. Like, I feel like I got tougher skin just walking to, my morning commute. And I would think about, wow, like if I was a nerve ending right now, I would be furious, right? And sometimes when you're walking around and you're getting bumped and like jostled, you're in the grocery store and someone's bumping into you and you're trying to just figure out what crackers you want to buy and you're like getting disrupted. Doesn't it become like an inflamed situation? Like you want to just be like, stop bumping me. That's exactly how nerves act. So cool. Now I know the nature of the nerve. I know why he's upset. I know where he lives. Do I know where he lives? Where does he live? Does anybody remember where the sciatic nerve is? Where is that in the body?
RS conjunction.
Just switch the page. Oh my gosh, I pulled out the wrong one for you guys. That's all right. I can still use this one. This one's actually femoral nerve, which is the front. So don't get confused by it. This is the sciatic nerve in the back. But the reason I like this one is because it shows the spine and where it starts. And this picture starts down here. There's a reason why I want to point that out. So yes, Gary, it starts in the lumbar spine, kind of middle of the way here. That's where the nerve root comes out. And then it has this beautiful pathway through the piriformis muscle, on the front side of the sacrum. Then it comes back out. It runs back out of the sacrum and pelvic puzzle here, comes down the back of the hamstring to the behind the knee, it splits again, and then it makes its way down the lower leg. Now, there's some trainings that I've been in, I'm sure you've been into this is not your first rodeo with sciatica, where they'll literally walk you through exactly where that nerve sort of trails through. And that's interesting. I find that very interesting. It's also where I find most of the confusion on handling the symptoms of sciatica, though. We tend to focus here, interesting that even the picture would show it. We tend to focus here on the relationship between the sciatic nerve and the piriformis. So the piriformis would be one of the deep six muscles that does lateral rotation of the hip, right? And here's what I want to appeal to you all. Yes, it's true that the nerves do not like to be messed with. They like assured clear distance. And yes, it is true that that's through the entire path of the nerve, not just parts of the nerve. It's the whole nerve. I'm on board with that. And I know, I'm not going to make you guys raise your hands, but I know that either you've done the work yourself or you know of colleagues who've done the work where they deep tissued that deep six and they put their elbows in the piriformis and they dug with thumpers into the back of the hips and it didn't help the sciatic pain, did it? No. Which leads us to say, well, then, hey, this whole focus right here is only a possibility. It's not really the whole kit and caboodle. So again, that's the common place that we go and why we don't solve it. But if we really want to solve the orthopedic problem, we got to look deeper and not focus on the symptoms. And if you were to find your way to anyone's deep six and piriformis, whether you were doing yoga stretches or personal training stretches or manually doing therapy with them on the table, I've not yet met a piriformis, and I'm sure you haven't either, that didn't respond to me finding my way to him. They all act like they need help. They all act like they need help. So then what happens is we get this picture in our mind of the sciatic nerve. We think piriformis because of that funky pattern that those two anatomical parts make, which there's nothing wrong with that, by the way. We're designed perfectly. And then we head into piriformis with whatever technique we have, and then we get a response and we're like, see, this is what it is. It's the tight piriformis that's causing the sciatica. But then we already confessed that doesn't solve it. So it can't actually always be piriformis in its relationship with sciatic nerve. In fact, most of the time it's not, especially if the symptoms are coming from that spot in the sciatic diagnosis. If the symptoms are here, can only be 10% chance that it's actually there. So we're just using the anatomy and the math to let us know, hey, wait a minute, that's actually not where I should be poking. It's uncomfortable for them. It's hard for me and it doesn't solve it. This feels like Groundhog's Day at work. You guys have Groundhog's Day? Tired of Groundhog's Day? I'm tired of Groundhog's Day too. Totally want you to have this. Okay, so then where do we go? It's simple, but it's not easy, but it's simple, but it's not easy. Meaning there's several steps to it. Here's what I want you to know. Again, anatomy driven. If the sciatic nerve comes from this area of the spine, and it does, and then it weaves down in here, and it does, and then it continues its journey, and it doesn't like to be infringed upon, what that automatically tells us is that everything it comes in contact with, not just the muscle, piriformis, everything it comes in contact with must be in an optimal space based on design, because there's nothing wrong with our design, or that nerve is going to be unhappy. It's just like you guys are nodding. You're like, yeah, it makes total sense. Exactly. So then what needs to be in position? Well, every place that there's a nerve root ending, Murph just threw his head on the floor. He's very impassioned about this right now. Everywhere where there's a nerve ending that comes out, every one of these needs to be in alignment. And when I say alignment, I'm not saying that you now need to use a chiropractor. What I'm saying is this is how we're designed to have this gentle curve here juxtaposed to this curve and this curve. And if this one's distorted, like the way we might all be sitting right now, that means that the nerve ending that's coming out of there doesn't have assured clear distance. And if it doesn't have assured clear distance here, it might also not have assured clear distance all the way down. But even if it did, it's already unhappy here. Okay, so the simple answer then is to restore the curve, not dig on the piriformis. Hello, just go to where it starts. The second spot, some people say, well, but Gina, I don't know. You're telling me that the piriformis shouldn't, isn't the issue, but one piriformis was different than the other. It was definitely the piriformis on my client. Great, I love that you noticed that. here's what we're going to do again. Use the anatomy to help us understand why was it one piriformis and not the other. If we're still, my friends, both manual and movement, if we're still blaming muscles for contracting, which is their job, and we're telling them that they're contracting when they're not supposed to, what we have failed to understand is why did they start doing that? Because why they spontaneously combusted is the issue, not that they did spontaneously become symptomatic. So we still want to look deeper. Why would one piriformis act differently than the other? It's literally the same premise as the nerve root in the lumbar spine. Because of its relationship and the piriformis making its way between the sacrum and the innominate and the rest of the muscles that are here in this area, because of its design, it absolutely needs this bone and this bone to also be in alignment the same way it needs these bones to be in alignment. And if one of these or one of these, or, well, there's only one of those, if one of these or this one are not where they're designed to be neutrally, optimally, organically designed, if one of them is askew from the other and it creates a non-assured clear distance from that nerve, there will be nerve symptoms. And one of those muscles, one of the piriformis, will act differently than the other one because they both require the same relationship from the bones that they interact with. They both require that. So if one piriformis is tight, my client really had his right piriformis, man. We stretched that thing for a good 4 minutes. And then I used the thumper. And then I put some herb product on it. And I really got it to relax. And then we made him move his leg. And I went back for more. And he was really doing deep breathing and got it. And I'm still asking, why was that piriformis that unhappy? Because it doesn't happen in a bubble. Something caused that muscle to do what it did. And it's not walking because we're designed to walk. It's not sitting because we're designed to sit. It's not being pregnant because we're designed to carry babies if we're female, like if we have a uterus, like it's like, so what caused it then? Muscles don't just spontaneously get unhappy from doing their job in our body. In fact, it's the opposite. They love to do their job. When we're not getting them to do their job, they're also unhappy. They have a different flavor to that unhappiness, but it's never because someone walked that they now have a back problem. Something was going on mechanically in the walking that needs to be addressed. And as we keep digging for that, you'll get closer to absolutely understanding the source instead of navigating symptoms. And, you know, you might feel productive if you're working on someone's muscle that's very reactive, and the client might feel like you're getting something done, but you both know that it didn't last. And that's where we're both disappointed. And then the Groundhog Day thing. So does this make sense to you guys on sciatica? Yes? Did you learn something new, or was this all repeat for you? Alexandra, did you know this already?
Mostly, yeah, like the sciatica nerve, and then just working on, you know, especially pregnant clients. It's all like in the back. It's also posture, the curve, like if they have a lordotic curve, like that's like all factors into, you know, what's going on back there.
Yep, totally does. And in an extended lordotic curve, like during pregnancy, what is your remedy for them to not have such an extensive lordotic curve? Do you have one?
Not really. I mean, I try to, you know, do like a gentle stretch on them to kind of like pull, trying to, you know, correct it a little bit, but I don't really have like an exercise for them to do.
Okay. Are you open to me giving you some intel right now?
Oh yeah.
Yeah. Okay. So this, thank you for sharing. I love this. Even if we're not dealing with pregnant clients, what I'm about to share for you, Alexandra, and a pregnant client applies to all bodies, believe it or not, because again, we just want to use the anatomy to help us with the answers and not get distracted by all the things, experiences that the body is having. So here's what I know. When we're navigating an excessive lumbar curve, which needs to happen because there's extra weight in the front during pregnancy, especially late-term pregnancy. The reason why these muscles, the paraspinals along the spine, and some of the others in that same area, think QL, for example, one of the reasons why those muscles feel tight and have more tension, even turgor in them, is to prevent this body from face planting while their belly is growing. And the body does it naturally. We don't have to tell it to do that. Isn't that cool? Like the body just figures out how to keep us upright. How freaking awesome is that? The body figures that out on all of us. We don't have to be pregnant to have that be the experience. Our body's figuring that out on all of us. So when we have an excessive lumbar curve, because of the weight gain and weight distribution taking us forward of the axis, while these are getting tight, what we actually want to avoid is trying to release them. Because if we release them, now we have no stability to keep them upright in the axis. Now what's going to hold them up if these are tight? And that becomes true for even clients without pregnancy. If we don't have enough strength and stability, and I'm going to get there, if we don't have enough strength and stability in the lever system on both sides of the spine, which we can see obviously in pregnancy, if we don't have equal strength and equal length to both sides of the lever, one side is going to get tight because it's going to be bracing and recruiting. If we take away the bracing and recruiting, we have no stability then. So what ends up happening is the body goes back to bracing and recruiting because it knows it's smarter than us. It doesn't want us to fall over. So what would be a longer term solution would be to not just release here, but to add more strength here, right along the spine, not ab crunches, because obviously in pregnancy, we can see like that's not going to happen, right? We're 8 months into a pregnancy. We're not going to start doing crunches. Hello, that would be ridiculous. And I love using pregnancy as this example because we're like, well, then what else would we do? Well, then what else would we do? Well, then what else would we do? The same thing we would do for all bodies in this situation with an excessive lumbar curve. If this is too tight because it's bracing and recruiting, it means there's not enough strength on this side. So how would you add strength on this side and what would you add it to? What muscle holds the spine in this arrangement, this lumbar curve? What muscle does that? Any muscles come to mind? Alexandra, I'll volley it to you.
Iliopsoas?
Yes, exactly. Exactly. So how could you, and you figure that out with your clients, we all get to figure that out with our clients. How could you engage iliopsoas and add strength to it? Obviously, with a woman who's 8 months pregnant would be different than a dude, right? Who's 6'2" and able-bodied. Also different from someone who's in a different age bracket, who might have just had hip surgery. So it's different for all of them, but we do know that that's the solution. How you do it is specific to the work that you do, but that is the solution. What's not the solution is releasing the support that the body has designed on its own. Because again, this is also fun to see it here too. These muscles didn't just spontaneously get tight. And we think, well, no, of course, Gina, I know it wasn't spontaneous. It was because there was a baby growing. Right. But our body is able to do everything we ask it to do. So why did there become a spontaneous interrupt then? Because something was missing to be able to do that thing, that action, that life, that physical experience. And we're able to do all of it. We just need to have the right equipment and the right balance in the right places to be able to do that. So I love this. Does that support you, Alexandra?
Yes.
Yes. Okay, great. And if you have this imbalance here, whether we're working with a body that's pregnant or not, the same thing would happen with the nerve endings. Do you see that? If these muscles got very contractile and turgor stressed, and the space between the spinous processes became smaller because of the increased lordosis, do you see how the sciatic nerve could be really like reactive? And then we would get a doctor's diagnosis for our 8-month client, 8-month pregnant client. And we'd be like, oh, well, you have sciatica. Okay, that's a fixed stamp. Can't do anything about that. When really it's not even sciatica. It's not even sciatica. What it is an imbalanced lever in their structure. That's what it actually is. So then you give a pregnant lady a diagnosis and she's like, oh my God, am I even going to be able to deliver? What's that going to do? And then she's walking around with fear about delivery for something that's so frustrating. So I love that we don't get to diagnose. And insofar as I could treat really helped me. Well, then what would it be then? What are the parts and what are the parts doing? Not what is the diagnosis stamp? What's that fixed, idea around it? Okay. Is this valuable? Is this clicking? Getting good nuggets here? Okay, I want to move on to another common diagnosis. You guys ready to switch lanes? All right, rotator cuff. Rotator cuff injuries. I don't know yet of a manual or a movement provider who hasn't come across a rotator cuff something or other. Either your client came to you with it, they came to you after it, they came to you before it, and then stopped coming to you because then they had it. But I feel like we've all met somebody along the road that's had a rotator cuff injury. Am I right about that? Have you guys all met somebody along the road with a rotator cuff? Okay, great. And the common culprit for the rotator cuff, well, so the common culprit for the rotator cuff, I'm laughing because of what our client's common knowledge of it is. The common culprit is the muscles that do medial and lateral rotation, hence the phasic action of the rotator cuff. Makes sense. That's what they do. That's what we're pointing at. Rotator cuff muscles do those actions. Those are the ones that are torn. Those are the actions that need to be restored. Makes sense, right? No. No, it shouldn't make sense anymore. I'm here to change your mind about that. Okay. And what's really interesting for me is that every client that I've ever had that's been through physical therapy with a rotator cuff injury is how adorable. They call it the rotator cup. And they've not been made aware that there's 4 muscles, and they're not even really aware of what those muscles do. They just know what the homework is. And there's not really anything wrong with that. Like, our clients don't really want a whole anatomy lesson, or they would have gone to school to do what we do. It's not really what they're there for. However, we need to have enough anatomy to be able to explain to them what's going on and how they got into the predicament that they got into. Now, only in rare instances where there's like blunt impact trauma, like some outside force actually created enough torque that the relationship between this bone and this bone became wrenched, and then the muscles tore. Unless it was that, most of the rotator cuff injuries and surgeries are for far lesser tears, tiny little ones. Physical therapy, like the tear isn't big enough to do surgery. We're going to send you to physical therapy. We're going to see if it works. And if it doesn't, then we'll talk about surgery. That's not a major tear. That's not like this bone is at risk of falling off. That's just a little tear somewhere, right? Most of the rotator cuff tears fall into that category. And every single client that I've ever had with rotator cuff rehab came back to me after their rehab and they didn't have 100% restored. That also doesn't work for me. Doesn't work for me with my clients, and it doesn't work for me that that's their experience. So the common culprit is that the medial lateral rotators of the shoulder, that are the 4 muscles of the rotator cuff, are torn or damaged, and that's the quote unquote rotator cuff injury. And again, unless there was ravaged injury in a dramatic direction to a muscle that does lateral or medial rotation of the shoulder, I'm not hearing how it would tear. If I don't even hear how these muscles could spontaneously get tight, I definitely don't hear how they spontaneously tear. What the hell? We literally have anatomical parts that prevent that. So there isn't anything spontaneous about it, again, unless it's blunt impact trauma. So then what is it then? That's the question I want to ask you. I want you guys to answer. I want to ask you, and I want you to ask yourself, what is it then? If it's not a injury to the medial and lateral rotators of the rotator cuff, then how come there's a rotator cuff injury in front of me in this client? What's the source of that? What caused that? Gary, you have an idea? You came off mute.
Overuse of the muscles in a certain direction, usually with weight.
Okay. So it could be external weight is definitely a factor. And we're also designed to lift heavy things. Okay. I'm not saying you're wrong. I'm using our logic here because I want you guys to think deeper. And I don't believe in overuse because most of us are underusing. What is often classified as an overuse is a misuse. You can't contract your muscles and use your body too much. We're literally designed to move. So, are there rest moments in between workouts? Of course. Are we supposed to be running 24 hours a day? No, that's why we fall asleep, even if we don't want to, because our body is smarter than us and it will put us at rest and it will make us fall over and lay down to do that. So yes, of course I believe in rest. And so I'm not being weird about it, but overuse, like I walked too many miles. No, I lifted too many whatevers. No, I hugged my grandchildren too many times. No, like, do you hear it? Like, that's not really what's happening, but misusing is the key. And that's what causes injury because we're not designed to stop We're designed to move. So it's how we're doing the movement again in the same way we just talked about with sciatica, actually. It's not that we did something, it's how we did it. So commonly we look at the medial and lateral rotators, and even though it is actually an injury to one of those four muscles that physically does medial and lateral rotation, what I want us to also look at, and what I looked at when I figured this out, was, well, what else do those muscles do? So if I have these four muscles in my shoulder, and you do too, and so do our clients, if I have these four muscles in my shoulder, and I'm designed to move, do I really believe that those four muscles just do nothing most of the time? Because medial and lateral rotation is kind of a specific action. When's the last time you remember doing medial or lateral rotation in your shoulder? Did you do it today? Maybe. Did you do it today? Gary, what did you do that was medial or lateral rotation of the shoulder?
I reached for my computer and I picked it up.
And how did you do medial or lateral rotation doing that?
If it was medial rotation to reach for it and lateral rotation to pick it up or hold it, that sound right?
Almost. I can see where there could be medial rotation in the work you just did, but I did not see lateral rotation. So if you took your hand and reached for your computer and your computer was here, that's medial rotation. You can see it up here. But if I pulled it back, I just pulled it back to neutral. I didn't laterally rotate yet.
Oh, yes.
Got it?
Correct.
Okay.
Yeah, thank you.
Yeah, lateral rotation is not that common. I have to think every day, like, did I do it today? I don't think I did it today. Did I? Did you, Alexandra? It looked like you said you did do medial lateral rotation today. Did you?
I thought I did. Maybe not though.
Okay. Do you want to share it so we can workshop it out together?
Oh yeah, no, I guess yeah. Picking up my 1-year-old probably didn't. Like if I was like doing something and then like to reach out, if my arms were, I guess, like this, and then I reached out to her, I kind of medially rotated.
Yeah, there could be some medial rotation there. Yep. And then shoulder flexion, sure. But what about lateral rotation, right? If we know that lateral rotation looks like this, how many of us did lateral rotation? Jean, did you?
Yeah, because I'm always pulling back my shoulders constantly, like stretching back there.
Okay.
Stretching doesn't exist, but I do that constantly.
You know, I love when you talk like that. I love it. Okay, so like deliberately taking your hands behind you and like interlacing them behind your back. And still, if you're a movement provider, just because your clients have hyperextended their shoulder and taken their arm behind them, it doesn't mean that it equals lateral rotation. So, right, I can take my arms, and we see this a lot actually. You take your arms behind you and the elbows stay bent. There's no lateral rotation there. That's actually medial rotation. And it's not a medial rotation that's an action that we're looking for. It's a compensatory response, which is even less joint action of medial and lateral rotation. The only way we have lateral rotation is if, look at Murph's rivet here. The only way we have lateral rotation is if the ball rotates in the socket. Just taking my arm behind me doesn't do that. It can if I also laterally rotate while I'm there. So this is just helpful for us to remember, like joint actions help us remember, oh yeah, joint actions mean there's a muscle assigned. So if I'm looking at a rotator cuff injury, that is straight up 4 muscles, 1 of 4, sometimes more than 1 of 4. And those muscles do those specific joint actions. So how did they tear them? How did they tear? By doing too many arms behind my back? We just, like one of the 4 of us just did that today, right? So how then? Here's how. The other job that those muscles have, so first the highlight I was trying to make here is that we don't use these rotator cuff muscles as frequently as we think to do rotation, medial and lateral rotation of the shoulder. We don't. And the more I study the body, the more gobsmacked I am. There's not anything here that's superfluous. There just really isn't. There's always a need for it. And when it comes to musculoskeletal, the body is designed very efficiently. We're not just going to be handed 4 muscles that we barely use. It's just not the way we're designed. So then the question is, well, what else do those muscles do? Anybody know? What's the secondary and often overlooked role of the rotator cuff muscles? Medial and lateral rotation we got, but we already identified that's not their full-time gig. It's what they're known for, but it's not their full-time gig. What's their full-time gig? No idea. Isn't this fun? Isn't this fun? Now here's where the gold is about to pour out. So we know that when muscles move a joint, they must traverse that joint. And the rotator cuff muscles are on the scapula and they traverse the glenohumeral joint and they attach on the humerus to hold the humerus on the scapula while it's also rotating. The holding it onto the scapula is so important. And that we are doing 24/7 unless we're asleep. 24/7 is the phrase. But while we're upright opposing gravity, we're absolutely holding this bone onto that bone. Otherwise, how is it staying there? How is it staying there, guys? Gravity wants to pull that puppy right out. How is the ball staying in the socket? Muscles are holding it there because that's what muscles do. They hold and move bones. So if the rotator cuff's full-time gig is to hold this bone onto this bone, then what we really need to look at in a rotator cuff injury is that holding. Is the holding happening? Are these two bones in a decent relationship relative to each other for the holding to happen? Is there any other support that's happening in this joint? Or are we protracting our scapula and creating an imbalance in the optimal alignment of this joint, the same way we talked about down here? Are we holding our scapula in a protracted fashion that's making this stability more compromised, then using these muscles less, and gravity is a constant and pulling on it while these guys are getting weak and gravity hasn't given up at all? And we're not going to blame gravity. This is not a faulty design. It's a faulty owner of the design. The design's perfect, but how we use it is not. And most of us have protracted scapula all freaking day long, which means the glenohumeral joint is not in a neutral alignment, which puts a ton more strain on the muscles that hold the ball into the socket, the glenohumeral joint together, which are also needed then to do something dramatic like medially and laterally rotate our shoulder. So when we talk about like in sports, and it's tough to talk to a baseball player, I've done it, and they're like, Gina, you're smoking crack. I'm not smoking crack. You just don't want to hear this because it's going to change your pitch. But if we're talking about medial rotation under force on muscles that are not in a healthy position to stabilize in the first place, they're already in a compromised arrangement. And now we're going to put torque on them. And back to your idea, your initial idea, Gary, about external weight. We're designed to hold external weight, but not if we're out of alignment structurally. We can't even carry our own weight if we're out of alignment structurally. And again, I'm not suggesting that you need a chiropractor in this situation because a chiropractor doesn't teach someone to stop protracting their scapula. That's an inside job. That's an inside job. That's not an external technique job. But we need to know the anatomy and then how to explain that and then be able to walk our clients through that. So every time that I was met with a rotator cuff injury, one that was avoiding surgery or who had surgery or who had been through physical therapy or who was headed through physical therapy, it was getting worse and not better, which is also a thing. Every time I focused on not the medial and lateral rotation of the situation, but I focused on the stability of this bone on this bone and the alignment between the two, meaning just like the alignment here that I had to focus on, I needed to strengthen the stabilizing muscles that hold these two bones together and make sure that they weren't being pulled apart too frequently, which would weaken them. We need to add more strength, not release and stretch everything. And that's why I say, Jean, and thank you for quoting me, stretching doesn't exist. And you guys remember, my career started as a manual practitioner. I just had enough movement in my background that I started noticing, hey, wait a minute. And it doesn't even mean that you have to have movement in your background. This is just straight up how the body is designed. It's just designed as a lever where both sides of a joint have to have equal strength and equal length. Both sides of the lever have to have equal strength and equal length. All practitioners that study the body know that, but now we're applying it, right? If you've been a massage therapist, you hadn't applied it because you didn't think about movement in that way. And if you were a movement practitioner, you might not have had that anatomy might not have clicked in that way. It doesn't matter. It just matters that you're getting that information now. And then how do you address them? So it's not that I am opposed to stretching. I'm not. Even on the opposite side of the lever, lengthening is occurring. It's a naturally occurring event in the body. But to just go after something and release it because it's uncomfortable, or stretch it because it's uncomfortable, or thump on it because it feels tight. Can you imagine? Now, see, Murph really wanted you to hear that too, because he threw his head off again. Can you imagine if these rotator cuff muscles, who are supposed to hold this bone onto this bone, were uncomfortable because they were in a dire situation? Wouldn't they feel tight? Yes. And can you imagine if we released them, they would be doing less of what they're trying to do by recruiting. It's not too different than the scenario we pointed to down here. These are tight for a reason. These are tight for a reason, to try to hold this guy up there, try to hold him up there, especially as you're lifting 1-year-olds at home. Your body is trying to get you some stability to be able to do that, so this bone doesn't rip off this bone. So if we released it, we wouldn't really be helping. Our clients would feel good for the hour that they're with us, but that's not the solution. And I know you guys are here for solutions. So is this interesting how two totally different diagnoses kind of have the same basis of finding the source and solving it? Yeah. And that is what we spend the year studying together in our mastery program. And I'm just letting you know, it takes a minute to get all this, but then it covers all the bases, which is what I love about it. Okay. How about we move on to, does anybody have questions on rotator cuff? Can we move on to a totally different, Gary, you got something? What's up? His head's under the chair now.
So,
Yeah.
so what's the fourth area, the fourth muscle other than the subscap? Is it the infraspinatus in the shoulder, the four muscles?
You're asking me what are the 4 rotator cuff muscles?
Yeah.
I'll give you the acronym for them and I want you to go find them. Okay. Yep. The acronym is SITS, S-I-T-S.
F is in Frank.
Nope. S like sitting down. S like Sam. SITS, S-I-T-S. Supra, infra, teres, and sub. Supra, infra, teres, and sub. Okay. SITS muscles. Always the 4 muscles in the rotator cuff.
Thank you.
You are welcome. Any other questions on rotator cuff or what to do about it? Okay. Amazing. Let's move on to plantar fasciitis, shall we? I love this one. Okay. I remember being at a, I think it was a 50th birthday party. It's a couple of years ago. And I got invited to a birthday party and a bunch of women were all hanging out in this beautiful Airbnb. I think it belonged to one of them actually, in Florida with a pool, no boys, no neighbors. We had music, we had wine, we were having a great time. And girls were being silly and they were jumping around dancing and doing all the things. And sure enough, right in the middle of this fun party, not one, but 2 of them said, "Oh my gosh, I just peed my pants." And I was like, what is happening? Like, what the hell is happening here? Are they drunk? And that wasn't it. It was what causes this, that scenario is the clue that I'm going to tie plantar fasciitis together. Okay. Just hang with me if you've never heard this before. And immediately when I heard that they were, jumping around and peeing themselves, I asked them, do either of you have plantar fasciitis? And they laughed and said, "Oh my gosh, she's a witch. How do you know that?" "Yes, I do. Wait, I got orthotics." And then they all just started talking about all their plan. "I had it. I got rid of it. I did this. I used to have it. I had it in one foot. Then I had it in another foot." And none of them realized at that moment that the question I had about their plantar fasciitis was absolutely tied to them jumping around and peeing on themselves. And I'm here to tell you they're the same. Okay. Compelling, isn't it? All right. Plantar fasciitis commonly is blamed on the foot, the fascia of the foot, the shoes that you're wearing, because the foot doesn't like the shoes. Podiatrists will treat it. Interesting tidbit that podiatrists by law can only work from the tibia down, so they don't even work upstairs from there. Folks with plantar fasciitis have orthotics. They can only wear certain shoes because they think it's the shoe. And I'm here to tell you that none of that is true. None of that is the solution. That's just a lot of busy work because that's not where it comes from most of the time. And when you ask somebody who has had plantar fasciitis and how they resolved it for themselves, they'll tell you some version of, "Oh, well, I did exercises for my foot. I rolled on a tennis ball. Every once in a while, I'll hear something that makes me very happy. They'll say they stood on a towel and their homework was to crunch up the towel with their foot. And I love that because I'm about to show you how this all rolls out. But that is rare that a client of mine will tell me that they actually did foot exercises and that's how they got rid of their plantar fasciitis. Most people will say it just stopped. Have you guys had, yeah, it just stopped.
I actually had plantar fasciitis after my first pregnancy. I did stretching. I tried to figure out what was going on and then eventually just went away. I'm like, oh. I didn't know. I couldn't tell you like what I did for it to go away. It just went away.
That right there. I'm so glad you just said that out loud, Alexandra. If I could capture that in a bottle and package it and sell it, I would, because that is the standard answer. And I love that you said after you gave birth, because there is definitely a connection. And I love this for your pregnancy clients as well. So this is, I'm hoping, is going to just light up your life. Okay. So one of the misnomers about plantar fasciitis is that it's in the foot, and more commonly, it just spontaneously goes away. Here's what I want you guys to remember about the body as you're solving and sleuthing and resolving orthopedic issues. Things don't just magically disappear. They don't magically show up. They don't spontaneously just appear out of ether. And they don't just disappear. Every time our body gives us information like that, oh my gosh, the bottom of my foot is screaming at me, or oh my gosh, I can't even laugh without peeing my pants. Anytime our body gives us information like that, it's information. And for those of you who have little people at home or who are pet lovers, you know that not everything needs to be communicated through English language in full sentences that don't end in prepositional phrases and proper punctuation marks. You can still communicate. The body is trying to do that. And our job, I believe, as practitioners is to be able to have really strong assessment skills, to be able to hear between the words and the implications of what those words are. And we do spend a lot of time learning that. It's simple, but it's not easy. But once you get it, it changes the whole game for everything. So in the bottom of the foot, there are more than a dozen muscles that are responsible for making this shape of the foot, this domed arch here. More than a dozen muscles. And when we look at the foot, especially when we talk about fallen arches, but when we look at the foot, we might believe that we actually don't have this shape. But the truth is we do all have a version of this shape. None of us is made. These bones, if you look at the bottom, these bones don't even come available to have a collapsed arch. They just don't. And I know I'm blending diagnoses here, so I don't want to get us too far off track. I mean, I'm still on plantar fasciitis. The point is that there are muscles in the foot that we all came with. There's 4 layers of muscle in the foot. More than a dozen of them are responsible for holding up this arch, and we all have one. Doesn't have to be a high arch or a low arch, doesn't matter. We have an arch. And those muscles are designed to oppose gravity to hold this arch away from the earth. That's a different group of muscles than phasic. We started talking about them with sciatica. They're intrinsic muscles. We talked about them in Tuesday training today. We've been talking about them all month. Period on the end of that idea. All muscles have a sheath of fascia wrapped around them. And you don't have to be a fascia expert or a fan of fascia or anti or pro fascia, just to know that that is the way muscles come. They come with a sheath of fascia around them. You don't have to be a fascia expert to also know that fascia is a continuous sheath. It doesn't have endpoints like muscles do. So while this muscle, I'm going to use my hand, while this muscle has a attachment point and an attachment point and fascia that wraps around it, and it does, this muscle has an attachment point and an attachment point and fascia that wraps around it. But the difference between the muscles and the fascia is the fascia doesn't stop. The fascia is continuous between the two. Even though this muscle has a stop start and this muscle has a stop start, the fascia that wraps over each of those muscles also continues with itself. Okay, and that's really important here when it comes to plantar fasciitis. In the definition, in the words of the diagnosis, we think it's plantar, the bottom side of the foot, fasciitis, inflammation of the fascia. It is, but here's the key. Just like muscles, fascia doesn't spontaneously just become a jerk and just, arbitrarily pick an inflammation point. I'm throwing Murph's body all over the floor. Fascia doesn't just spontaneously erupt and become like argumentative for no reason. It responds negatively to negative forces. That's just what it does. And that's an is. Okay, and you're all nodding because you get that. So we're using our anatomy to walk us through, pun intended, this very common diagnosis that's often misrepresented as being a foot problem or something that'll just disappear over time. It doesn't disappear. Okay, in the bottom of the foot, the two main muscles, there's more than a dozen that make up this arch. Two of them, you know the names of, peroneus longus and tibialis anterior. They create the stirrup on the arch of the foot. Peroneus longus on the bottom of the foot also trails up the side of the fibula, right? And then it has its stopping point at the fibula. Just because it stops there doesn't mean the fascia stops though. The fascia from the hamstring, one of the hamstrings also attaches in the same spot. And now that fascia sheath is continuous up the hamstring, which then also goes all the way up past the femur and into the sit bone, where the hamstring also attaches and ends there. But just because that muscle ended there, the fascia didn't end there, because the fascia is continuous head to toe, which now means that that same fascia is now connecting to the next closest muscle, which is a pelvic floor muscle. Okay, so now we've traced the fascia from the arch of the foot to the pelvic floor. And that fascia is not happy. It's responding to force and it's inflamed because it's responding to force that it doesn't like. It's responding to a force, a pressure, an imbalance. Okay, you guys following me, right? So now we know just by following the fascia, which is in this diagnosis, that if we stopped at the bottom of the foot, we would be short-sighted. We would be short-sighted if we stopped there. Because fascia is one system, and we just traced it from the arch of the foot to the pelvic floor, and then it goes from there. But we're just going to stop there for a second because Alexandra gave us some really good intel. The pelvic floor is not a phasic area of muscles. It's an intrinsic area of muscles. It's designed to hold organs up away from gravity. That's not the only place that intrinsic muscles live. I started our conversation by saying there's more than a dozen right here that hold this arch up away from gravity as well. So if there's more than a dozen muscles here that hold this arch away from gravity and they share fascia with these muscles that are supposed to hold organs up and away from gravity, I think the issue here is the holding away from gravity or not. That's the problem, because the muscles aren't doing their job fully and the fascia is bound to do its job, pun intended, and it can't. And that's where the irritation comes from. And in addition to that, Alexandra gave it away. She said it was right after I gave birth. Right after these muscles, who are under duress during labor and delivery, are supposed to be holding organs up and in, but they've literally been forced in the opposite direction to give birth to this beautiful creature. But their job is to hold it up and in, up and in. They're a little weak right now. They just had another very important job and they're a little weak right now. So when these muscles get weak, the fascia on them gets irritated and it trails all the way down the leg to the arch of the foot. We just traced it. This is a fascia issue, an intrinsic muscle fascia issue that trails all the way back up to the pelvic floor, which is why when these women were jumping and laughing, the muscles here didn't have enough strength to hold their organs up and in, which is why their bladder released. And every one of them went on a boasting talk about their plantar fasciitis. Some of them, their plantar fasciitis spontaneously went away. Some of them can only wear certain shoes. Some of them got rid of it because they did strengthening exercises by pulling on the towel. Some of them did not get rid of it, even though they rolled the fascia out on a tennis ball over and over and over and over again. Rolling things out, releasing them and stretching them and doing deep tissue on them doesn't restore strength. And we already identified that a arch and a pelvic floor need strength. They don't need more releasing. They need to pull away from gravity. They need to engage, not degage. I just made up that word. Okay. Gary's deep in thought. Alexandra, you're nodding. You're like, that was me. She just described me. Was that, what was your experience?
Yeah, wow. That was definitely, I think, because I know I try to do like pelvic floor exercises because after my first pregnancy, I felt like, I had a little bit of incontinence. So I felt like, I need to strengthen those muscles. So I did a little bit of that, seemed to have gotten better. And now I'm thinking, oh yeah, my plantar fasciitis, I guess, kind of went away because I started strengthening my pelvic floor.
Yay, you just tied it together. Yay, I'm so happy for you. Yes, exactly. Really well done. Great. Jean, what clicked for you?
Yeah, everything just came together, those the plantar fasciitis. So the question is, being the age of 50, are you going to be able to jump up and down for 20 minutes at a time and dance?
Yes,
Ever?
100%, 100%. So in the conversation that we just had about intrinsic muscles this month in Tuesday training, and
Mhm.
in the course that's in the club, we dive deep into intrinsic muscles. And I'll give you the shorthand of it right here. The shorthand of it is there's nothing faulty with our design. We're designed to be happy on the planet and thriving the whole time we share space with the planet. And these muscles are strengthened by opposing gravity. So just like any muscle, you either use it or you lose it. You're either using them to oppose gravity and getting them stronger, or you're not. So again, pregnancy is such an easy way to see because we're just like, oh, it makes so much sense with pregnancy. Oh, wait, but that still applies to me. So we'll just use that again. So in an instance with pregnancy, when these muscles are getting, put under a lot of duress, and then delivery, if it's vaginal delivery, or even if it's C-section, then they're all cut into. That's even a longer healing. But once the delivery is, underway, these muscles are getting pulled down towards gravity, and their strength is in the opposing gravity, not towards gravity. So to answer your question, even if I wasn't talking about a pregnancy, if I haven't opposed gravity here, over time, gravity is still pulling them towards it. It's not an age thing. We like to say, oh, well, once you hit that certain age, no, nothing. Once you hit a certain age, that's a nothing. That's an excuse for not engaging. So once we know to engage, then we do. If we don't know to engage, we don't. And then gravity just keeps pulling, but we're smarter now. And that's the value that we're offering our clients too. So it doesn't matter what age you are, you still have those muscles. Use them. They will get stronger, and then you can jump all you want and dance and sing and frolic and all the fun things. Did that answer it for you?
Yes.
Okay. Yeah. We don't want to get ourselves pigeonholed. I'll be right with you, Gary, into thinking that at this age, then it's the same energy as a diagnosis that is fixed and fearful. And it's just not true most of the time when it comes to the body. That's one of the reasons why I'm lit up by sharing this information with all of you. So then you can go out and share it with all the people that you serve. We can have a different idea about the body instead of all walking around in pain and afraid and medicated. Yeah. Okay, Gary, I'm all ears.
So last week I had a client who had a number of aesthetic operations, a tummy tuck, etc. And now she's not able to walk long distances because she's incontinent. So again, it's that, what am I doing to my walking that's causing the incontinence? Or was there something in terms of adhesions or something that was causing the intrinsic muscles not to be able to function, to be weak, that would cause the incontinence? So now I'm thinking, is it something in there, or is it really just weakness of the intrinsic pelvic floor muscles?
Well, incontinence is definitely tied to intrinsic pelvic floor muscles because literally the muscles hold the bladder up and in and also hold the sphincter closed. And you bring up a really thoughtful point. Were there adhesions before the surgery that were making it difficult for her to engage intrinsically? Maybe. I don't know her history, but I'm guessing that if someone had surgery of the type that you're describing, strengthening exercises weren't part of her regular routine. So it doesn't mean that it could just mean, it doesn't mean that there were adhesions that were causing it. Her lack of engagement was what was causing the incontinence, right?
Okay.
But the other thought that comes to mind for me, and I don't know this particular client, but it rang a bell while you were raising your question. Everything that I'm sharing with you guys is about how the body's designed, how it's designed to move, how it's designed to give birth and all the things. But once we start removing parts or invading, like through surgical and then removing parts that way or adding parts, the anatomy is still the same. And now there's another thing to consider. And typically what I have seen with practitioners is that practitioners will jump to there's more to consider because of this life experience. Like, well, but I'm a horse rider or I'm a gardener or I had 3 kids. That's not the circumstance to consider making extra concessions for as much as alterations to the apparatus. Those you definitely need to make considerations for. And still, the anatomy is what the anatomy is, and the body wants to be restored. So even when we have alterations, some of the discomfort is because the body is trying to get back to its original before we altered it. So we still get to know that original anatomy and how it functions, and then how to return it there. And with that, I wonder, so that's option number 2. And with that, option number 3 is, and don't plant the seed for her unless you know for sure. When we make an alteration to the body under like surgical interventions, we don't know what happens in those scenarios unless we're super clear and we demand that we get the notes from the surgeon. And so depending on what type of surgery is done, things can be nicked and bumped and bruised the way they're not supposed to. Like you've heard horror stories about they actually leave utensils inside someone's body and then their body has to reject them because the body's like, hey, I don't really need these tweezers in here. Could you please remove them, kind of thing? Because the body's smarter than we are. I am not suggesting that that happened with your client. Please don't go back to her and say that. Anybody who's watching this on the replay, do not misquote me. That's not what I'm saying. I'm offering that when there's an alteration, you need to consider last, not first, what happened with that surgery. And the only way that I would suspect it is if everything else I already shared with you in option 1 and option 2 about the way the body's designed and what the body actually needs, if I've exhausted that. So for example, if I had a client who told me that they couldn't walk without urinating, I would initially think intrinsic strength because I can do something with that. But it's also not common that you can't walk without urinating. Jumping, but walking. So now I'm a little bit like, what? And then if I walked them through intrinsic muscle work, which I know to do and I target it, it's literally a third of the Schatz method in our technique toolbox, and something didn't add up. Like I had her engaging intrinsically and she urinated more. That's literally backwards. Then I would be suspect of option number 3. I need to know that something could have been altered when someone's apparatus has been altered. And I'm not going to jump there first and make excuses for me and her to not fix it. And sometimes we do that too soon as practitioners. We're like, I don't know, it must be the thing she had done to her. No, just help her with the anatomy and how it's designed to work, and then keep a very watchful eye and ear on how the body responds to that before you make a conclusion that there's a diagnosis that is preventing you from doing good work.
Got it.
Does that help you?
That's a good, I mean, yeah, the strategic thinking in that way, that kind of funnel down is very helpful. Thank you.
Excellent. I love that you called it strategic thinking, Gary. I know you've been hanging out with our crew for quite some time, and it is one of the pieces. I'm going to end with this, guys. It's one of the pieces that I think is the most important for all of these diagnoses, all of these common chief complaints, all of the work that you're doing. I really want to appeal to each and every one of you and everybody in our industry, all of our peers and colleagues, that we get to really take ourselves on our thinking. We get to be steeped in knowledge, well-versed in skill, and absolutely committed to strategic thinking, or we will be replaced by robots. And I am not a conspiracy theorist. I'm not even afraid of that. But here's the thing. If you use ChatGPT and you love it, or you know someone who does, I don't. I'm holding out. I'm one of the last. But I recognize how fabulous it is. People have shared with me. I've been ChatGPT'd before. Used to be everybody was Googling everybody. Now you're all ChatGPTing each other. It's fascinating. Like, how do you know all that about me? I never told you. Who's you? It's just a very advanced version of what we used to do with Google and WebMD and all the places that we used to go search for information, which means it's loaded with information And for you to be more valuable to your clients, you've got to carry your weight. You've got to be loaded with information. And I know you're here. That's with me on that. That's why you're physically here with me today. You've got to know your shit. And then you've got to be able to think outside the box, which is something that those devices aren't doing. If you're not taking yourself onto that level and thinking outside the box, you are replaceable. And you shouldn't be, because the work that you're doing is so needed and incredible. So what will happen, I believe, is that there'll be a wave of replacement and then there'll be a wave back again. I don't want you to be caught in the riptide, right? I want you to be like soaring above, like watching above the water, being like, yo, guys, come play with me up here. So I love that you said strategic thinking, Gary. I'm super, like, that's my whole thing. I say it probably 6 times a week with my mastery practitioners. Like, this is what we're up to. It's why I hot seat everybody. I ask them a question. They ask me a question. I ask them 2 back before I even give them an answer, because I want their brains to be clicking. You can't teach someone to do that. You can only support them in their learning of that. And I really want that for you guys. So I deeply appreciate that you're here and like open to thinking outside the box. And I want to encourage you to keep doing that. And if you don't have someone in your life that helps you do that, find one. Like, find one. Once you start thinking in that way, you also recognize that your confidence builds, because you're like, hey, wait a minute, I can't be duped. Like, I got a thing or two. I'm calm. I know what's going on. I got this. I'm calm in my own body. I'm calm with my clients. I'm calm when the world's doing what the world's doing, because I can think clearly through complicated things like anatomical compensatory patterns and see right through the mess to the solution. That's what we spend most of our time doing in mastery, is thinking in that higher level way. So please keep taking yourselves on that way. All right, my friends, I had a blast. Thank you for showing up and contributing to such a fun conversation. I hope you guys left with, did you leave with something valuable? Are you thinking differently now?
Definitely.
Yes, thank you very much.
Definitely.
For sure.
Okay, I love the depth. Yeah, love that, Alexandra. Yeah, okay, good. Go get them, kids. Like, go do the good work. Yes, exactly. I don't mean kids in a condescending way. I mean it in a playful way. I really appreciate the work that you do in the world. I really do. It's like one of my dreams that before I leave this planet, everybody's got a different relationship with their body than what we currently experience. So I couldn't do it without you. Thanks for the work that you do. Hello, puppy. Me too, puppy. Yeah.
Oh my gosh, thank you so much.
Yeah, my absolute pleasure. All right, I'll see you guys on Tuesday training. Thanks so much for being subscribers. Thanks for following along and contributing. I'll see you guys next time.
Okay.
Thank you.
Bye.